The chief complaint is anemia, which I know is too broad of a thing, but I'll just leave it there for now.
All right, Archie, do you want me to start? Perfect. I'll keep it brief. When I think of anemia, my next question is like, okay, what is the tempo? As Robbie has taught us, tempo is queen and king, mostly queen, when it comes to anemia. So thinking about first thing first, I just want to make sure this is not an acute anemia. So the two things that I think about are acute bleeding and hemolysis. There are rare causes of bone marrow suppression that can cause, that presents as anemia, but like base rate, think about, I'm gonna have my antennas up for acute bleeding and hemolysis. And then if this is more chronic, then we get to have way more fun because it's gonna be a whole range of things to consider. I'll stop there and Lev, if you wanna give us more information.
I would just love to clarify that anemia is about 80% queen and 20% king, according to the laws of Charmaine. So yeah. Okay.
Thank you.
Sounds good. And I'll keep talking, and then you just tell me when you think is a good stopping point. So I'm going to make up the patient. It's like a 70-year-old woman who had a left hip replacement 5 or 6 years ago. And then the hip replacement unfortunately had some infections in it over the last couple of years. And the patient has had to come back and forth to the hospital to get like a washout and some other sort of procedures with the original orthopedic surgeon. About 2 months prior to the current presentation, the patient had severe left sort of thigh pain, came to the hospital, and on evaluation was found to be anemic. I forget what the hemoglobin was, but low. And then had a CT scan of their left lower extremity, which showed a large hematoma. At that time, they placed a drain, like IR, interventional radiology placed a drain, which had a lot of blood sort of come out. And after a few days of stable hemoglobins, the patient was discharged. They followed up with their orthopedics team every week to see whether the output of the drain had gone down enough to take out the drain completely. And it took several weeks for the output to go down to where they felt comfortable. And so they pulled the drain about 3 or 4 weeks prior to this presentation now. And since that time, unfortunately, the patient's thigh again began to hurt.
I think this is a great place to stop. And I think the rapid fire reasoning here would be to really map on this part 2 to Charmaine's initial conversation and say that you have anemia and you have blood loss, and the instinct is to marry the two and say this is blood loss anemia. And of course, the missing factor that often takes time is to prove that the time course of those two things aligns up. And that's how we prove this causation in medicine. It's very hard to prove that one thing caused the other, but if you align their time courses, the connection between the two tends to be more robust. But just because two things happen at the same time doesn't mean that they're causal. But if they happen at different time courses, the argument for them being related becomes much, much, much weaker. So here, it'd be really curious to see what the hemoglobin trend is in relation to the development of blood in the hip and whether those are fully related. And at first pass, the reason they may not be fully related is just because you've identified blood in one compartment doesn't mean that the patient isn't bleeding elsewhere, accounting for a further component of hemoglobin loss. But I think the other dimension to this case is why this patient is having blood loss in her thigh. And I'll pass the mic to Charmaine to share her thoughts on that.
Yeah, no, that's such that was fantastic, Robbie. You're absolutely right. So I think in terms of like kind of the blood loss in the thigh, and just to kind of circle back into places where you can in a body lose a lot of blood, like thigh is definitely one of them. You can put a lot of blood in there, and also like you think about your GI tract, you think about your lungs, you can think about like abdominal space. Too. So what we know about this patient is that that patient had a left hip replacement there, and now it's bleeding. one like hypothesis that we need to think about is that like, is this something post-surgical complications? We have a lot of vessels. Is there anything happened that caused the vessel wall integrity to not be there anymore, making it more like a structural abnormality that is kind of bleeding, whether it's kind of like, it is an inflamed place and you have like a fistula formation, you have like AVM formation, you have, again, like anything that can cause inflammatory processes that can cause that vessel wall not to be as sturdy and tight, and that is more prone to recurrent bleeding, especially if it happens exactly at the same spot. While that is true, the other thing we have to consider is that, is there any bleeding disorders, like any disorders of platelets, any disorders of your coagulation, the cascade that is and your clotting system that is making this patient on top of a structural abnormality more prone to bleeding. And those are like also like getting a good review of symptoms in this patient to make sure there's like no other bleeding from other places would be helpful. And as Robin mentioned, that in the back of our mind, also thinking about this patient at baseline has a reason for a chronic anemia that usually a lot of the time becomes a production issue. So those are like kind of the three things I'm playing around with in my mind. Anything to add to that, Robbie?
0. I love, give us more, my friend.
Sounds good. So with the thigh pain, and actually, maybe, do you want me to give you some labs as part of the story and then we'll get to the rest? Or do you want me to wait till like later to give you some labs in terms of time course?
However you want to put the story together, my friend.
Well, it might make sense to give the labs with the story.
Perfect.
So at that appointment where the drain was pulled, they ended up getting a hemoglobin of 11. And that's compared to a hemoglobin of 8 on discharge from the hospitalization. So it had improved a lot when they pulled the drain. And then the patient, because of the thigh pain, and eventually represented to the hospital to get an evaluation for the thigh pain. I think that's kind of that brings us to the present of the story. You guys had some questions about past medical history. Patient has atrial fibrillation, and the patient is on rivaroxaban for the chronic prevention of stroke in AFib. The patient drinks 4 beers per day and has been doing that for a long time. And I think the family history and the allergies won't be super relevant to this case.
Rivaroxaban, anticoagulation. I have a love and hate relationship with them. They're great, and sometimes they get us into trouble. So I think the question becomes if this structural abnormalities that we like kind of talked about that might be more localized to what has happened to the hip, is that rivaroxaban on top of that, is that enough to kind of explain it? And I'm not sure if they actually held the rivaroxaban or not in between the bleeding. And I think that would be informative to whether when the hematoma was formed, rivaroxaban was held until the drain was pulled, or it was determined that this patient is high risk that should we shouldn't interrupt the anticoagulation. I probably suspect the latter, that it was held. So I don't think that getting more clarification on that would be helpful. And then I'll pass the mic to RG to see if he has any thoughts.
Yeah, I think now you can put a narrative together. You can say that this patient has had tissue manipulation in this situation and has an anticoagulant on board. And that is probably the good operating hypothesis to put the entire story together. And the question will be, how can we make sure that we're not missing something underneath this story? And that will come by studying the platelets and the coagulation cascades closely, with the caveat that rivaroxaban can cause a mild prolongation in the PT and PTT. But if our INR comes back at 6, suddenly this narrative of surgery plus anticoagulant needs is weakened. And so I think that's probably the operating hypothesis before any data proves otherwise. All right, Lev, back to you.
Okay, I'll get into the exam. The vitals are all totally normal. Forget what they were, but it doesn't really matter. And like normal, so I should be clarifying. Temperature was normal. Heart rate was within between 60 and 100. The blood pressure was 130 over 70 or something. Respiratory was fine, setting without a need for supplemental oxygen. Very conversant patient, no issues there. Just profound conjunctival pallor on exam. The heart rate was regular, and both the rate and the rhythm were regular. No murmurs heard. Lungs were clear. Belly was soft. And on the left hip, there were some bandages there, and it looked just visually bigger than the right hip, although I did measure it, but there was no external bruising.
I'll just say something really quick, which is that if you want to get rich really quickly, make sure that you become an internist and make sure that you look under all bandages, because I'm telling you that surgeons know we don't look under these bandages and they hide millions of dollars underneath them. So here's your highway on 30-minute VMR to become very rich very quickly. Go and find bandages and cut them open. There lies in all the wealth. That's what I would do in this case. And I would wait for the current labs to guide the discussion, but I'm glad that there doesn't appear to be obvious consequences of this enlarging hip, meaning that in medicine, you have to know the cause, which we're studying very closely, but you have to be open to consequences. And the consequences of anything in the thigh could be the development of compartment syndrome, which based on the description of the distal extremity is probably not at play. So I think the question remains, why is this hip larger? Is it blood again, or is it something else? And if it is blood, is it the anticoagulant or is it something else? And those are the two open threads that I'm tracking. All right, Lev, back to you.
Okay, so I'll do current labs. Just to clarify, the hemoglobin of 11 was with that last appointment, so it was a while ago. I'm just going to pull up the medical record number and change it a little bit. Of course, on presentation, the hemoglobin was 6. The white count was 8, which is within normal limits here. The platelet count was 350, which is within normal limits here. The MCV was 98. And of note, and I'm looking back, the patient's MCV has been greater than 100 for all of these, like all previous months of blood work. On presentation, the patient's INR was 1.7. The PTT was 28, which is within normal limits here. Excuse me. And the chemistries, just say within normal limits. And then LFTs. So the patient's total bilirubin was 1.5, which is just slightly above the upper limit of normal here. The direct bilirubin was 0.7. And AST and ALT were within normal limits. And so was the alkaline phosphatase.
Julio. Lev, I'm loving this case. So looking at that hemoglobin, kind of like it tracks, right, with the acute blood loss that she's experiencing. So we've confirmed again, she's having acute anemia. Whenever I see that, I look back in the vital sign, and thankfully she's stable, so I still have a little bit of time. Cool. The platelets are really informative, right? So at least we know this is not a quantitative issue with the platelets being low. The question becomes, you also want to think about like, oh, if they can actually do their functions really, really well, like things like, antiplatelet agents, she's not on them. Uremia sometimes can cause dysfunction. So don't think that's an issue. Usually, like, whenever I think about acute anemia, I like always to think about hemolysis, but again, like MAHAs and those things are less likely in this scenario. Looking at that T-bully, a great mimicker of hemolysis is like when hematomas get reabsorbed. So I'm gonna give a note of that T-bully. However, I think it's most likely related to his hematomas being absorbed. But again, keep a note on that. And then it comes to our kind of like coagulation studies here, elevated INR. Again, with rivaroxaban, as Robin mentioned, it can cause some elevations. I think this is impressive, 1.7 for me. So I'm just going to take a step back and kind of like give a broad bucket and then pass the mic to Robbie. So thinking about, like we talked about our vessel abnormalities, we talked about our qualitative and quantitative platelet dysfunction, and then it becomes the coagulation cascade. In someone who's 70, then I would worry about more maybe acquired causes of the hemophilia and thinking about any reasons to have decreased von Willebrand factors. RG, do you want to like share your thoughts about what we this case so far too?
Yeah, no, I love it. I think we're on the right track, and we're seeing the hemoglobin dance along with the hematoma. So I think it's very reasonable to attribute the hemoglobin drop to that. And I think that Lev's close scrutiny of the MCV is commendable because it's weird. By the time that somebody bleeds this, while you can get a high MCV in the setting of acute blood loss because of reticulocytosis, this person is having repeated bouts of acute blood loss, and in sum total might add up to chronic blood loss, which usually results in iron deficiency anemia, which usually results in a drop in the MCV. And so the question is here, why is that not happening? And the truth is that story is one that doesn't always have to play out. It's not one that is consistently seen, but it forces you to question, is there a macrocytic anemia underlying here? And the retic count would help definitively answer that question if the retic count is causing the MCV. But here you might say, hey, is there an underlying cause of macrocytic anemia of which meds and nutrition account for the most? And there's no meds here, so it would be nutrition. Nutrition meaning B12, folate deficiency, copper deficiency. And why might that story be a narrative to explore deeply is because, as you pointed out, Charmaine, the INR is elevated at 1.7, and another nutritional cause is vitamin K deficiency. So while this is unlikely, probabilistically speaking, the MCV in the absence of reticulocyte counts or meds says nutrition, and then an elevated INR says nutrition. So here for me, I'm curious what the vitamin K response is, and does the INR go down with vitamin K? And is there a nutritional component of macrocytic anemia? But that is a low probability hypothesis. I think this patient seems to be anticoagulant intolerant based on their surgery, and imaging of that space may help us figure out like why they're anticoagulant intolerant, and maybe we can just fix this with zapping something or bandaging something on the inside. All right, Lev, take us home.
Okay, we can give a couple more labs. So the reticulocyte count was 38.0, and here we at my lab we do it based on the total amount rather than the sort of percentage. The ferritin was 334. The blood smear showed present hypochromia with platelets and WBCs unremarkable. What other information would you guys like?
Like, mind clarifying, is that retic count low? I actually don't know how to interpret it.
Sure, of course, yeah. So what somebody taught me this during residency.
Yeah.
I actually don't have like evidence for this, but I found it to be quite helpful. And I teach this to all the med students, and it seems to kind of work.
Yeah,
That you
that's like
have
99% of medicine, by the way. Like there's no evidence, and we teach it anyway. So
Right.
Totally get it.
I live next to a bus and the bus just drove by, so I missed what you just said. Apologies.
Oh no, I was just reinforcing the idea that like 99% is of everything we teach is no evidence and just based on a hunch seems to work.
Sounds good. Here's my hunch that I think is actually quite useful. If you make like XY axis, and on those axes, on the Y axis, you put the numbers 14 and 4 for hemoglobin. So like if 14 is on the top left and 4 is kind of on the bottom left.
Yep, I'm with you.
And then that's hemoglobin. And on the bottom, retic count, the absolute number, and you put 40 and 400, meaning a low retic count on the bottom left and a high retic count on the bottom right. You can actually draw a line from the top left of the graph to the bottom right of the graph for what you would expect the reticulocyte count to be. And just to like make that obvious, if your hemoglobin is 14, you can expect a retic count of 40. If your hemoglobin is 4, you can expect a retic count of 400. And I don't know if those numbers are like perfect, but it kind of brings home the point that you should expect a very high retic count when hemoglobin is low. If you apply that to here, where the hemoglobin is 6, you would expect the retic count to be in the hundreds at least. And here the situation is that it's 38. So the retic count is inappropriately low, even though within the lab value, it technically is a normal value, but it's an inappropriate normal value in this situation.
No, I think what the VMR crowd just witnessed is just how good of a teacher you are. You broke that down so well, and we're actually able to create an XY axis in people's imagination, which I think is very, very skillful. So thank you for delivering that. And I think the numbers sound so specific that it's hard not to believe that there's some data behind it, you know, like 14 and 4. I don't know. I believe it.
I remember it because the number 4 is in each of the four numbers, which is how I remember it.
Nice.
It's the 4, 14, 40, 400 sort of graph.
I love it. I think that's beautiful. I'll tell you, one of my favorite episodes of the Clinical Problem Solvers is our hemolysis episode. I vividly remember Charmaine giving a caveat about like sharing an approach for the retic count and giving some caveat. So I would love to hit play on that again and hear it live.
So yeah, retic count is great, and it's a great marker. One thing that I've learned actually is that it will take 4 to 5 days at times for it to actually respond. So if the patient is like, again, this is like we say like she normalized and that she had another acute drop, it actually might take the bone marrow a little bit of time. So think about like, oh, is there a reason for hypoproliferation? However, I would just trend that in a couple of days, and if it bumps back up, then you think, all right, we're cool. Bone marrow is cool.
And I know we have to close out. I think I would love to hear what your guys' thoughts are on what the next step would be in sort of evaluation of the problem, because I don't have all the answers yet.
I personally would love a CTA of that leg to kind of like think about like the caveat with the CTA is that depending on the rate of the blood flow, whether we would actually see something, it's always questionable. However, just given the temporal relationship, the fact she's on anticoagulation, I definitely want to take a look at, think about the vessel integrity in that area. And if there's any extras, would be helpful for our IR colleagues to think about. Anything else that you would do, Robbie?
The less important thing to answer acutely is to answer, why does the patient have macrocytic anemia? And here the patient does not have reticulocytes. And so the question is, does she have any one of these things? And we know she's not on any medications. We know it's not reticulocytes. We didn't hear a prominent drinking history. Her liver enzymes are normal. And there's no evidence of hypothyroidism or myeloma otherwise. So I think the key question is, does she have MDS? Does she have a nutritional cause of macrocytic anemia and a nutritional cause of a bleeding propensity with vitamin K? So I think what I would do is exactly what you said. I think explore why this person is bleeding in this specific space by looking at it, and then explore the possibility that the patient might have a bleeding propensity with nutritional causes of bleeding and nutritional causes of macrocytic anemia. So I think I'd probably get a CTA and a B12.
The B12 was normal. I don't have the results of the CTA yet. A key question I had was, can you blame alcohol for, like, how can you, it's kind of a diagnosis of exclusion in some way, shape, or form, but when can you officially say that this is just alcohol related macrocytic anemia, and how do you make that call? Open through the group, because I don't know the answer to that question.
No, I completely missed the alcohol in the history here, just to show you that sometimes when you don't really have a rich understanding of the problem you're trying to solve, details don't necessarily stick. And I think just now it became clear that macrocytic anemia is a problem that we're trying to solve, and now the alcohol history becomes prominent. And proving that any toxin caused any disease is always hard, and more definitive. Like you can ask the same question as, how can you prove that hydroxyurea or methotrexate is causing the macrocytic anemia? And often you rely on sending tests that are more definitive, like laboratory tests. But I think it's a good working hypothesis when you have a normal B12 and no meds on board. And the best way, I think, is to stop the toxin and see what happens to the MCV.
Yeah.
Thoughts, Charmaine?
I agree.
That's all I got for now. I don't have the final answer yet.
Oh, I love fresh cases. That's so good for thinking. Would you, RG or Lav, would you send any other like hematologic studies at this point, or would that be like your second passport workup?
Sure. I mean, what are you thinking?
Like, thinking about more like acquired issues.
Oh.
My approach was like at the CTA, think about again like nutritional deficiencies, hold that rivaroxaban, see how she does, and if she continues to bleed, and if there's any more like systemic signs of bleeding, then I would think about more like acquired factors.
In this patient, I think the INR just kind of went down with time, and they were holding the anticoagulation. So for me, at least, that was good enough to blame it on the medicine in this situation.
I love it. Yeah, I would have done the same thing. I would have just waited to see where she settles. Oh, I can't wait to hear an update. Lav, whenever you get the updates.
Sounds good.
I absolutely love this case, because if we were doing the usual VMR, you know what this case would end up with? This case would end up with nutritional deficiency causing a bleeding. It would end up with scurvy causing bleeding in the hip and peripheral hemorrhages and gum bleeds. It would end up with all sorts of esoteria, but this is real life. And as Ravi's saying, amyloid angiopathy. But real life is that you often actually don't come up with the specific explanations for things, and common diseases are so common. People bleed after surgery, period. That's it. Like, that's what happens. And so especially when they're on anticoagulation, they bleed a lot when they happen on surgery. So I really thank you for calibrating the scales here. This is maybe the first ever common VMR presentation, and now we're over 450. So the probability of common diseases on VMR was less than 1/400. And thank you for finally raising it from 0. Appreciate it.
Awesome. Absolutely. I couldn't have said it any better. Love common diseases too, and common presentations. Thank you all. Who's doing our teaching point today? The amazing Daniela. Woohoo. Take us home, friends. Such a privilege, Lav. Thank you. RG, always a pleasure. It's so good to be back. Daniela, take us away.
Yeah, so hi everyone. This is actually my first time doing teaching points. So it was very exciting, and yeah, let's do it. So first of all, we have a case that the chief complaint was anemia, and we have to consider if it is acute or chronic anemia. And in this case specifically, we had to think about if this anemia was caused by blood loss. And in that case, we have to consider if the timing lines up, if the bleeding is matching the time of the anemia. But even then, we have to remember that even if the patient is bleeding, that is not necessarily the cause of anemia. And then we went on to think if the surgery is the possible cause. Is it due to loss of structure, a structure abnormality? Is it due to tissue manipulation? And all of these are possible causes of what is leading up to these anemia and the complaints of the patient itself. And we, even if the history is leading towards acute, we also have to consider chronic. So always keep that in the back of your minds. And in regards to hip enlargement, we kind of brushed on compartment syndrome, which is most likely not likely. And with labs, we saw that a low hemoglobin leads us to think about acute blood loss, like in the beginning, hemolysis, and we always have to think if it is a quantitative or a qualitative issue. With macrocytic anemia, we have to consider possible causes. The most common that probably so wonderfully mentioned is nutritional due to medications, bleeding, or alcohol, like Lev mentioned as well. In nutritional, we have B12 and folate. And if it is due to meds or alcohol, we can test by withdrawing the possible cause. And like Lev also wonderfully explained, in case of a low hemoglobin, most likely we have a high reticulocyte count. And in this case, we could see that even though the hemoglobin is low, we had normal reticulocyte count, which is abnormal in this case. And with all that, we also have to consider vessel integrity. And yeah, that's it. I'm very nervous, but
You did
with
so
that,
well. That was so good.
thank you.
You know what I loved is I think you kept it really, really focused on what we talked about. It's so easy to decorate it, but look, look at your slide deck. It's 6 teaching points, which is way, 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 way more impressive and thoughtful than 30 because people can only remember so much, you know? Alrighty, thank you all.
Thank you.
Great job, Daniela. Have a great Thursday, everyone. Bye.